Thank you. So good morning, ladies and gentlemen and dear colleagues. My name is Arnold Bosman. I'm a public health epidemiologist based in the Netherlands at the company Transmissible. And I'm very grateful for this opportunity to speak with you and to share some views on the value of open access tools for the analysis of public health data, but also the challenges of the interaction between the public sector and the private sector and the community, where an increasing amount of initiatives can be seen in analyzing and interpreting the data. So this talk is about emerging community initiatives during the COVID pandemic. It's also looking at open access tools for public health data analysis that become available to a much wider audience. And in addition, what challenges does this bring for managing public health evidence and managing the public debate and the communication about public health evidence? So first, let's look at some observations from the Netherlands perspective on the first 6 months of the COVID pandemic in 2020. The WHO labeled COVID-19 as a public health event of international concern on January the 30th. And those of you who will have vivid recollections from that period will probably remember that it took some international debate for, when the WHO would actually declare this situation a public health event of international concern according to the IHR 2005 rules. A bit more than a week later, on February 8, ECDC published a set of guidelines that summarized the knowledge up to that moment. And among many things that were in these ECDC guidelines, they suggested that schools could be a major driver of transmission of these type of viral respiratory diseases, even though they admitted that for this particular agent, more evidence was needed to be clear about this. But the warning in the ECDC report was clear. Also, we saw that on February 11, the WHO was very adamant about warning the world about the risk that COVID presented, and they labeled it public health enemy #1. They urged us with the recommendation, you need to hit fast and you need to hit hard. And they warned against complacency. Now, it took still a month for the WHO to label the entire event a pandemic. But what could we observe meanwhile of those first episodes in the Netherlands decision-making? And I'm now looking mainly at the decision-making of the Dutch National Scientific Advisory Group that advised on the COVID control policy in the country. And what we could see that in that early February, mass gathering events could continue. And there was a debate about whether or not the national celebration of Carnival at the end of February should continue. And it was stated that Carnival would not present a huge risk of transmission for COVID, and it could continue between the 23rd and the 26th of February. Now, the first COVID case was reported on the 27th of February, and that was in a person returning from Italy. And at that time, only people returning from COVID-affected countries were tested for COVID. Now, by March 12th, the regional services in the Netherlands indicated that the numbers of new cases had increased so exponentially that they exceeded their capacity to control, and they were abandoning the strategy for containment formally. And a few days later, the Dutch Prime Minister on the 16th of March announced formally that in the Netherlands, the herd immunity approach would be the tactical and the strategic approach to deal with the epidemic, which means that natural infections among non-risk groups are to be encouraged. And they advocated for controlled spread based on the advice of the Scientific Advisory Group. At that time also, we noticed that the National Outbreak Management Team communicated that school children are not an important driver of transmission, even though the evidence for that statement was lacking. A month later in April, we noticed that lab capacity failed to scale up sufficiently to apply to all the testing needs required. And also, investigative journalists disclosed economic interests between the National Scientific Advisory Group and some diagnostic laboratories. So this generated, in general, a public controversy and a question marks about the Central Advisory Group. Then in May, there was another public controversy about the national contact tracing protocols that conflicted with ECDC guidance and WHO guidance. Also, the possibility of aerosol spread was denied by the National Scientific Advisory Group, and the effectiveness of masks were rejected. But meanwhile, several external experts were increasingly voicing critical views from the community to the government policy. And that led in June to the creation of an alternative scientific advisory group called the C19 Red Team. This Red Team takes the position as an alternative scientific advisory group. And in the previous pandemics, there were formal after-event reports that concluded that the Dutch National Outbreak Control Team was vulnerable for tunnel vision and for groupthink. And therefore, it was recommended already 10 years ago that to set up a mechanism for organized contradiction, as it was called. But this recommendation was not implemented. So the Red Team saw the need for critical review of the national policy as an important value and a contribution to the Dutch pandemic response. The group consisted of 12 experts from multiple disciplines, including microbiology, epidemiology, anthropology, health economics, governance, community nursing, mathematical modeling, data science, complexity science, and public health research integrity. The team published daily data analysis on various social media channels and shared the data analytical scripts on GitHub. The reports were also published on recommendations, and often they were called controversial at first, but they were later adopted, especially when it is about the effect of masks, the effect of aerosols, schools, etc. So behind this team of 12 experts, a community has grown also of over 200 people. And this community made sure that all the 12 members of this central team were also reviewed very critically on their turn, also to avoid their own version of tunnel vision and group thinking. The interesting thing is that even though the central group of Red Team disbanded in 2021, to this date, the community of over 200 people are still very active, and they're still very much contributing to the public debate. Now, there were also other community initiatives for data analysis in the Netherlands. And if this would have happened when I was still working in the National Surveillance Institute in 1998, I think I would have embraced this with open arms, because it is really clear that we always lack capacity for data handling, analysis, and interpretation when we are faced with large crises like this. You simply do not have enough hours in a day. But only now, with the social media ecosystem on the internet, these phenomena are really allowed to flourish, but they also bring their own set of challenges. So let's take a look at, what would be the conditions for such an ecosystem of community-based public health data analysis to flourish. Well, first of all, I believe you need open access to social media, because we're usually talking only about communities generating activities online and at a distance. So that also requires certain sustainable and reliable community platforms, such as Discord. But that's not enough. That's the technical part. What the community also needs is a shared sense of purpose and community objectives. And in addition, what they need is accessible technical tools and open data, for example, via GitHub. But especially the technical tools are really interesting, and we'll come back to that later. So besides that, they probably also need to have a consensus about methodology and interpretation. But most of all, they really need lots of energy, patience, and good humor, because the effect itself is, and the activity itself is quite challenging. Now let's take a look at the free tools that we have available internationally. And I want to name just two out of them without any illusion that this is a limitative list of tools. But I just want to highlight the Kobo toolbox and Go Data from the WHO, because I believe they're not only great and valid tools, but they are very accessible and they're user friendly. And the most important thing, I believe, is that they're case based. And especially Go Data has been developed by the WHO to deal with outbreak situations where you can have case-based recording of cases and of contacts. And the interesting thing is that if I look at most of the industrialized high-income countries, they consider Go Data as a non-issue, something that is probably only designed for lower and middle-income countries. And this is a perspective, I think, that we further deserves discussion. So there are, of course, other case-based platforms like EpiInfo, but it's not so user-friendly in general, but it requires much expertise, and then you have a lot of bespoke programs. Now, the general challenges with all of these publicly accessible tools is, of course, standardization, and part of that was also shown a little bit in the previous presentation by Sebastian Vulker about, how to make sure that you have comparable geographical information as well. But also background data are relevant, and I want to point out two really important sources like mobility data from Google and from Apple. But also, I think in this conference we can have the discussion: what can we expect from EpiGIS in this respect, in terms of being available for a large group of people in the community, and how should it be used? So I also mentioned some of the methodological challenges, and again, this is not a limitative list, but I'm mentioning some of the challenges that were really sources of public dispute. And for example, if you look at contact definitions and case definitions, for example, if you have a formal national definition of a risk contact which excludes people at school, then as a bias in your system, you will never collect data that will actually disclose the risk of schools. If your interviews of cases and contacts are lacking specific directions of potential sources, then your data will never generate robust evidence that will incriminate those sources. Then you have the diagnostic bias. I mentioned in the beginning that only people who are arriving from countries that had proven COVID circulations were tested, and which means that in hindsight, we really missed a lot of national transmission at the local level, because obviously the virus was already there long before the first case was identified. Traditionally, there is always challenges in comparing lab tests between labs and between countries, but also harmonizing data aggregation about age groups, for example, or geography. So these are in general the challenges. Now, we definitely ran into one of the problems that data interpretations really carries also a lot of political debate and political values, because there were a lot of public disagreements about how to interpret population-based risks. So if decision makers have already made a decision that certain risks are absent or are present, they may be really sensitive to opposing evidence. And in the same time, we need to realize that people who work in the public sector, experts working in the public sector, they must communicate within that policy context, that this is a necessity, which will also influence the way how they feel, how open they can communicate about question marks that are still there. And especially if you look at how to do the risk assessments, that really depends on so many factors, like the way you define the contact, the way you access all the contact data, or you perform the interviews. And the most challenging thing is about attributing the risk. And I'm thinking about the very long and first discussion about the role of the wet market in Wuhan, and which evidence really supported that this was one of the origins of the outbreak. So the topics, I believe, for discussion coming from these experiences and observations is about, the availability of validated analytical tools. We use the tools that we were mentioning, also because there is a large amount of trust among the expert staff in their validity. But what we haven't thought about so much is what are the mechanisms that we need to have a public scientific debate? Because whether we like it or not, we live in a completely different society than 10 or 20 years ago. And a scientific debate is per definition public because of the fact that social media and the internet is ubiquitous. So the question then about how to engage with the community is a really important question. I believe we can be certain that it doesn't work top down, but what are the options how to really integrate useful initiatives from the community to really benefit the public responsibilities? So I think the key question maybe is how to leverage the capacity to generate public health evidence between the public sector and the community. So I would like to leave you with this perspective. Just as a closure of this presentation, and I'd like to thank you very much for your kind attention. I'm really open to hear your questions. Thank you very much.